Okay, in our video series of pulmonology lectures, in this video, we are going to talk about sarcoidosis. We are going to discuss the clinical presentation, sign and symptoms, diagnosis, and management of sarcoidosis in detail. First of all, we have a case here. A 38-year-old lady presents to your clinic complaining of a dry cough for the last 2 months. She has tried all remedies, but the dry cough isn't going away. Patient complains of some tender nodules over the shin for the last 1 week. When you auscultate the chest of the patient, what you hear are the fine crackles that are present. Then, when you order the chest X-ray, you see bilateral hilar lymphadenopathy. This is a classical presentation of a patient with sarcoidosis. What is sarcoidosis? How does it present? And how do you diagnose and treat it? Today we are going to talk about that. Sarcoidosis is a chronic systemic granulomatous disease characterized by non-caseating granulomas involving multiple organ system. Remember, sarcoidosis is a systemic disease. It involves the nerves, it involves the heart, it involves the liver, kidney, and the skin. And in all these areas, it forms granulomas, and these granulomas are non-caseous granulomas. Non-caseous granulomas are the granulomas that do not have any central caseous necrosis. They form non-caseating granulomas throughout the body, and all the manifestations of these disease are due to these granulomas that occur in sarcoidosis. They involve multiple organs, and remember, lungs are almost always involved. In almost 90% of the cases, lungs are always involved in the patients of sarcoidosis. It most commonly involves females as compared to males, and the average age of this disease is from 30 to 55 years. Remember, sarcoidosis is a condition that is yet not known properly. The cause is not understood yet. It is most likely idiopathic condition. We don't know the cause, like why it happens. But most patients that have sarcoidosis have a genetic predisposition, like someone else in the family is also suffering from sarcoidosis. And some exposure to substances like beryllium and its salts and a past tuberculosis infection has been shown to be associated with sarcoidosis. Now we are going to discuss the proposed mechanisms by which these granulomas are formed. Still, the cause is not yet known, but it is said that when a person inhales a foreign agent and that foreign agent is taken up by alveolar macrophages take up that foreign agent, as well as the dendritic cells, they become activated and they bind to these new antigens that are present in the foreign agents. These alveolar macrophages, these dendritic cells, will actually cause the inflammation. These dendritic cells will migrate to the lymph nodes and tell the lymph nodes that there is some foreign agent present in the lungs. Then in the lymph nodes are present immune cells. B and T cells are present in the lymph nodes, and these B and T cells get sensitized and they are recruited in these places, and inflammation begins. Inflammation starts. B and T cells start the inflammation. So alveolar macrophages take up the foreign agent, dendritic cells get activated, they take it to the lymph nodes, tell the B and T cells that some foreign agent is here and get ready for an attack, and therefore immune system attacks these foreign agents, resulting in the formation of granulomas. Granulomas are activated huge macrophages, and they form a bundle of macrophages. They collect together around this foreign agent, resulting in granuloma. But remember, these are non-caseating granulomas. They do not have a central necrotic area. Other than that, whenever a foreign agent is inhaled, alveolar macrophages get activated, and these alveolar macrophages get converted to multinucleated giant cells, epithelioid cells, and these multinucleated giant cells, epithelioid cells, form these granulomas. Now, these multinucleated giant cells and epithelioid cells have a very important role in the pathophysiology and mechanisms of clinical symptoms that with which these patients present. These epithelioid cells then produce angiotensin converting enzymes, and angiotensin converting enzymes produced by these epithelioid cells results in more inflammation. So this repeated cycle of inflammation, where we don't yet know the exact cause, that where is the inflammation actually starting from, but there are repeated cycles of inflammation again and again and again in the body, resulting in granulomas formation everywhere in all the organs of the body. The whole system is involved. This is sarcoidosis. Granulomas everywhere in the body. Now coming to the clinical presentation, how do these patients present? These patients will most likely be asymptomatic. Many times it will happen that these patients will be asymptomatic and you will be screening these patients for something else, and incidentally on the chest x-rays you would find bilateral hilar lymphadenopathy. I will also explain the chest x-ray findings later. These patients might be asymptomatic, or these patients can have non-constitutional symptoms like malaise, fever, anorexia, and lungs are almost always involved. These patients can present to you with dry cough, dyspnea, chest pain, and when these patients present with the symptoms of lungs, and if you auscultate the lungs, you will find coarse crackles or fine crackles in their lungs. In the skin, it results in the formation of erythema nodosum, painful nodules over the shins. In the eyes, it can result in anterior uveitis, inflammation of the choroid, inflammation of the iris, inflammation of the ciliary body. It will present with a red inflamed eye where there is photophobia, eye pain. This is a picture showing a patient with anterior uveitis. So the main presentation of sarcoidosis in eye is uveitis. It involves the musculoskeletal system and results in arthralgias, arthritis, inflammation of the joints. It can also involve the heart, and involvement of the heart can actually be deadly for these patients. Remember, sarcoidosis can result in arrhythmia, sarcoidosis can result in conduction blocks, sarcoidosis can result in heart failure, sarcoidosis can even result in restrictive cardiomyopathy. Remember, the heart involvement in sarcoidosis is very important. If the heart is involved, it can be actually lethal for these patients. Nervous system can be involved, and most common complication of sarcoidosis in nervous system is Bell's palsy or facial palsy. Remember, it will be asked many times in the MCQs as well, that what is the nervous system manifestation of sarcoidosis? It's the Bell's palsy. Lupus pernio is the pathognomic feature of sarcoidosis. If you find lupus pernio, it is a pathognomic feature of sarcoidosis. It is a rash that is present on the face, on the cheeks, and it looks just like the butterfly rash of SLE. Why does it occur? It occurs because in the dermis there are epithelioid granuloma deposition. So everywhere in the body, in the nervous system, in the heart, everywhere in the eyes, in the joints, granulomas are there and they are causing the manifestations. A simple mnemonic that can be used to remember the many clinical manifestations of sarcoidosis is grueling. G for granulomas, there will be granulomas everywhere. R for arthritis, joints are involved. U for uveitis, inflammation of the eye. E for erythema nodosum. L for lymphadenopathy. I for interstitial fibrosis in the lungs. We will discuss that in a while. N for negative TB test. Remember, whenever a patient of sarcoidosis presents to you, these patients will be having granulomas everywhere in the body. Now, there are other conditions that can also have granulomas everywhere. Conditions like tuberculosis, conditions like fungal infections. So, it's very important that you rule out tuberculosis in these patients, because especially in developing regions, these conditions are more common. Tuberculosis is more common than sarcoidosis, and tuberculosis also have a multi-system involvement. So on biopsy, you will be able to find that there are non-caseous granulomas, and non-caseous granulomas are seen in sarcoidosis, while caseous granulomas with central necrosis are seen in tuberculosis. So these patients will have a negative TB test, and they will have gamma globulonemias. Gamma globulinemia shows antibodies. These patients are having high level of antibodies because, as we said, that there is continuous immune response going on in the body. You will find high level of antibodies, that is called as gamma globulinemia, high level of antibodies in the blood. So you can remember the mnemonic grueling to remember sarcoidosis. Now sometimes you will also be tested about the variants of sarcoidosis. The variants of sarcoidosis include Lofgren syndrome. In the Lofgren syndrome, there are three things. Migratory polyarthritis that usually involve the ankles, erythema nodosum with bilateral hilar lymphadenopathy. If you find these three things, this is a classical Lofgren syndrome and it is a type of sarcoidosis. Another variant is Hereford syndrome. In Hereford syndrome, you will see Parotitis, inflammation of the parotid gland, uveitis, inflammation of the eye, and facial palsy. You can simply remember it with a mnemonic puff. Parotitis, uveitis, and facial palsy. That is Heer-Ford syndrome. And many times if you find these type of variants, usually biopsy is not even required to diagnose sarcoidosis because these are very pathognomic and classical for sarcoidosis. Now coming to the diagnosis of sarcoidosis. In the diagnosis of sarcoidosis, it's very important that you rule out all other important causes of excessive granuloma formation, all the conditions that involve all the systems of the body, all the conditions that can cause lymphadenopathy, conditions like tuberculosis, conditions like fungal infections, conditions like Hodgkin's lymphoma, conditions like leukemias that can cause generalized lymphadenopathy. You must rule out all these conditions and then diagnose sarcoidosis. Sarcoidosis on chest X-ray will appear as bilateral hilar adenopathy. Patients will have bilateral hilar lymphadenopathy, as we had in our case that presented to us, that lady, 38-year-old lady that had that bilateral hilar adenopathy. Now, many times it will happen that the patient will come for a general checkup and you will be doing routine investigation, and incidentally you will find out that the patient has bilateral hilar adenopathy, and when you investigate you find out that the patient is having sarcoidosis and patient is asymptomatic. Many times this will happen to you. On the basis of chest X-ray, staging of the disease is also done. Stage 1 is the condition where there is bilateral hilar adenopathy but there are no parenchymal infiltrates. I'll also show you an X-ray. In stage 2, there will be hilar adenopathy, there will be hilar lymph nodes, bilateral hilar lymphadenopathy with parenchymal infiltrates as well. Now, if you see the X-ray in stage 1, there is just the lymphadenopathy, bilateral hilar lymphadenopathy, parenchymal infiltrates are not there. While in stage 2, if you see, there is bilateral hilar lymphadenopathy, and with bilateral hilar lymphadenopathy there are these chest infiltrates, the parenchymal infiltrates that you see in stage 2. Now in stage 3, there will be diffuse parenchymal infiltrates without hilar adenopathy. There will be diffuse infiltrates but there will be no adenopathy, that is stage 3. And in stage 4, there will be excessive pulmonary damage, pulmonary fibrosis with honeycombing, fibrocystic parenchyma. The lungs will be completely destroyed in stage 4. Now this is the picture showing stage 3. You won't be able to find hilar adenopathy in stage 3. There is no hilar lymphadenopathy in stage 3, but there are these diffuse parenchymal infiltrates throughout the lungs. That is stage 3. And in stage 4, there will be total destruction of the lungs. There will be complete fibrosis, and in such cases when you order the high resolution CT of the chest, you will find total destruction of the lungs. And according to these stages, prognosis depends. Stage 1 patients have very good prognosis and stage 4 patients have very poor prognosis. Many of the stage 1 patients won't even require treatment. Now with chest X-ray, there are certain labs that you can perform that can support the diagnosis of sarcoidosis. These are not the diagnostic labs. Angiotensin converting enzyme is not the diagnostic thing for sarcoidosis. Remember, it can be elevated in 75% patients of sarcoidosis, but it is non-specific. And why does angiotensin converting enzyme is elevated? Because we discussed that epithelioid cells produce angiotensin converting enzyme that causes more inflammation. So angiotensin converting enzyme is a non-specific thing, but it can be elevated in 75% of the patients. Now in the patients of sarcoidosis, you will see hypercalcemia and hypercalciuria and many signs and symptoms of hypercalcemia. Why does hypercalcemia occur? Because these activated macrophages that we have in the granulomas of sarcoidosis, these activated macrophages produce 1-alpha hydroxylase, and that 1-alpha hydroxylase activity in these macrophages results in activation of vitamin D, and therefore vitamin D gets activated and resulting in hypervitaminosis D, because there is no feedback mechanism to these macrophages to stop having this 1-alpha hydroxylase activity. Therefore there will be excess of vitamin D, and that excess of vitamin D will cause activation, absorption of calcium from the gut, from the intestine. There will be increased calcium absorption resulting in hypercalcemia, hypercalciuria, calcium in the urine. Remember, cardiac sarcoidosis is very dangerous. Whenever you suspect a patient has sarcoidosis, you must always do cardiac evaluation. You must do ECG in these patients to rule out any blocks, any arrhythmias, because cardiac sarcoidosis can be deadly in these patients. Now remember, chest X-ray is just an initial investigation for sarcoidosis. It can give you a hint that patient might be having sarcoidosis. And ACE levels and hypercalcemia are non-specific tests. The main investigation, the most important investigation, the gold standard, and the investigation that is going to give you the definitive diagnosis is bronchial biopsy. Biopsy is the most important investigation. You go inside the lungs, you take the biopsy, and when you look it under the microscope, what you will see is that you will see non-caseating granulomas. This is diagnostic. Remember, the most important investigation is biopsy to diagnose sarcoidosis. Initial investigation is chest X-ray. Non-caseating granulomas will be there. With that, asteroid bodies. Asteroid bodies are star-shaped bodies that are seen in these giant cells. Schaumann bodies are also inclusion bodies that are seen in these giant cells. You just need to remember their names so that whenever these names appear, you do not get confused. But still, there is investigation going on that what these exactly asteroid bodies are and what these Schaumann bodies are. These are certain inclusion bodies that are present in these giant cells. This is the histology picture showing non-caseous granulomas. Look at the inflammatory cells, the collection of inflammatory cells and macrophages in it. Now coming to the treatment of sarcoidosis. Remember, sarcoidosis is a self-limiting condition and many patients will have sarcoidosis and they may be asymptomatic, and even if they develop symptoms in stage 1, it usually most of the time resolves by itself. Therefore, as I said, that it is a poorly understood disease. It is a disease that is not yet properly known that how does it occur and how does it self-resolve all by itself. Multiple granulomas all over the body, and then those granulomas go away. But in certain cases where the patient is very symptomatic, where the patient is experiencing many symptoms, in such cases, first line treatment is glucocorticoids. Why are we giving glucocorticoids? Because we want to suppress the immune response, because we want to suppress the formation of granulomas. Therefore, glucocorticoids are given. The glucocorticoid of choice is prednisone, 20 to 40 milligram per orally daily. Now, if the patient is not responding to glucocorticoids, or if there is any contraindication to use the glucocorticoid, in such cases you can start the patient on disease modifying anti-rheumatic drugs like methotrexate. Methotrexate is a preferred drug for the treatment of sarcoidosis in case glucocorticoids cannot be used, or if there is no response to the glucocorticoids. Other than methotrexate, azathioprine can be used in combination with the steroids. Chloroquine can also be used, and biologic agents like TNF alpha inhibitors, the drugs like infliximab, TNF alpha inhibitor. TNF alpha has a very important role in the inflammation. As I say that it's a general of the army of immune cells, and when you catch the general, the army cannot act properly. The immune system cannot act properly. TNF alpha, if blocked, the immune system cannot form these granulomas. So TNF alpha inhibitors can also be added to these patients. So remember, in the initial stages, the disease is self-limiting in some patients, but if the patient is having severe symptoms, you can use glucocorticoids. If there is no response, then you can give methotrexate. Remember, there is increased risk of lung cancer since there is repeated cycle of inflammation going on, and that repeated cycle of inflammation can result in lung cancer. These patients can have pulmonary complications like bronchiectasis, pulmonary hypertension, and pulmonary fibrosis. Now coming to the prognosis, remember, increased calcium indicates renal involvement and there is risk of renal failure in these patients. And prognosis also depends upon the staging that we did with the chest X-ray. In stage 1, there will be 70% chances of spontaneous remission. In stage 2, there will be 50% chances of remission. In stage 3, there will be 20% chances of remission. And in stage 4, there is limited life expectancy because the lungs are completely destroyed. This staging is based on the chest X-ray that we discussed. If you like my video, please make sure to click the subscribe button and make sure to check out my other lectures on pulmonology lectures, rheumatology lectures, emergency medicine, cardiology. I have whole playlists on my channel. We talked about what is sarcoidosis. Granulomatous systemic disease forming non-caseous granulomas most commonly affects females. Cause is idiopathic, not yet known. most likely a foreign agent is inhaled that results in activation of macrophages, dendritic cells, activation of B and T cells that results in granuloma formation, and multinucleated giant cells and epithelioid cells are there that produce ACE angiotensin converting enzyme that results in more inflammation. Patient can have lung involvement in majority of the cases. Skin, eyes and musculoskeletal system can also be involved. Erythema nodosum, anterior uveitis, heart involvement is most dangerous. Nervous system can present as facial nerve palsy. Lupus pernio is pathognomic, grueling, a mnemonic for the symptoms and the clinical manifestations. The variants like Lofgren syndrome, Hereford syndrome. We talked about chest X-ray as being the initial investigation, the staging according to the chest X-ray, the different stages of sarcoidosis. Cardiac sarcoidosis must do ECG. Definitive diagnosis, the main investigation, gold standard investigation is biopsy. You see non-caseous granulomas, first line treatment is glucocorticoid. If there is no response, then you can add methotrexate. Increased risk of lung cancer in these patients. Prognosis depends on the stage of the disease. If you liked my video, please click on the subscribe button and make sure to check out my other lectures on neurology, pulmonology, cardiology, nephrology and emergency medicine. The link of those videos is given in the description below. Make sure to follow me on Instagram, and you can also support this channel to make more free videos on Buy Me a Coffee. Thank you very much.